I am Saren Kohli. I am the Director of Communication at Africa CDC. Our host and lead panelist today is Dr. Jean Kaseya, Director General of Africa CDC. Dr. Kaseya is also joined by Senior Technical Expert on the Incident Management Support Team, IMST, and other heads of division across Africa CDC. As usual, the briefing is available in English and in French through interpretation. You can use the language icon to select your preferred language. Let's now join our speaker. Over to you, Dr. Kaseya.
Good morning, good afternoon, good evening for some of you. Thank you for joining this press conference. In addition to other colleagues, we have the great honor to have Professor Salim Abdul Karim, who's the chair of our ECG, Emergency Consultative Group. This is the independent group that is making recommendations to the DG if we have to declare or not a public health emergency of continental security. What is good, Professor Salim landed to Ituri. He's taking this call from Ituri together with some of our colleagues. And welcome, Professor. We will not waste time. We'll start with our slides. Yeah, next slide. This week, we received the visit of Ajal Habib, the EU Commissioner for Equality, Preparedness and Crisis Management. She went in Ituri to see what exactly is going on, and she came to Addis to discuss with us on the effort that we are making to stop this outbreak. And as you know, she committed 11.5 million euros new funds to Africa CDC. That is bringing the total contribution of Europe around 80 million since we declared the outbreak, coming from many other sources. Next slide. Yes, our colleagues are in Mongwalu. That is one of the regions where the outbreak can be considered as the epicenter. And today we have also colleagues in Beni and other places, including Kampala. I want to say thank you to our colleagues for their hard work and dedication. We can see how the ministry is working closely with WHO, Africa CDC, and so many other partners. It's an opportunity for me to really thank the partnership that we have with WHO on the way to respond to this outbreak. Next slide. I wanted to discuss with you this slide, a lot of information. When the outbreak was declared on 15th of May, we have 3 health zones. 7 days after that, we had 3 provinces, 11 health zones. 5 days later, still 3 provinces, but 14 health zones. It means 5 more health zones. But almost 10 days after the 27th of May, we moved from 14 to 27 health zones. It means we are doubling the number of health zones affected in 10 days. But more importantly, look in terms of cases, confirmed cases, and per provinces or country, you will see that we have 600 cases in Ituri. Out of the 600 cases, we have 104 deaths. That is giving the case fatality of around 17%. And what we call the contact list, we have 4,955. What it means, when we have an Ebola outbreak and we are in an urban area, an area with high density, mostly driven by mining activity, we are expecting around 40 people to be contacted for one confirmed case. Then, this one is a critical information because in Ituri, out of 600 confirmed cases, we are expecting around 24,000 contact lists. Out of the 24,000, we just have 4,955. And out of the 4,955, we only have 57% of those in the contact list who are monitored, followed. That is giving an overall 12% of people who are expected to be in the contact list who are followed. This is a major indicator for us. In Ituri and in North Kivu, you will see the percentage of what we are expected, we are expecting to have in the contact list is low, and the percent of people who are followed is again low. If you have this kind of figure, you will see that in the next slide. Next slide. In this slide, we are presenting what we're expecting. As I said, if we take a total of 635 confirmed cases, this is the total for the two countries, for DRC for now, and Uganda. If you see the number of contact lists is 6,022. We are expecting around 24,000 people to be in the contact list. This is giving us only around 17% of people expected contact who are currently under active follow-up. If we don't reach out to all of these people, yes, 40% is the ideal one, but we can accept between 20% to 40%. Knowing the context of Goma, knowing the context of Ituri, we want to talk about 40%, at least 30%. This is what we are giving you as range. We are saying between 17% to 34% of expected contact are currently under active follow-up. If we don't know these people, if we don't have them in the list, if we don't follow up, it means there is a huge risk of transmission to be sustained in the community. What is making also this response difficult? It's because we still have some confirmed cases not admitted. They are somewhere in the community, elsewhere, but they are not admitted. It means if we don't reach out to all of them, those we know they are already confirmed, those who are contact, we cannot say we can control this outbreak very soon. Keep that, because this is the main indicator that is now driving our response. This is why we are building our capacity in terms of surveillance, in terms of lab, in terms of communication to reach out to all community and leaders at community level to help us to share the best information to communities. Next slide. We know this slide already presented, I think, when we launched the joint response plan. This outbreak, the current one, is almost 5 times what we saw in Uganda, 17 times what we had in DRC in 2012. It means the burden of this the current outbreak is exceeding the 2 Budubungu outbreaks that we know in the past. Next slide. In terms of number of confirmed cases, for now, this outbreak is the 3rd one, the 3rd Ebola outbreak out of the 20 historical Ebola outbreaks that we had. We hope we can stop that and it won't move from the 3rd to the 2nd, even the 1st one. Next slide. What we see, wanted to zoom in terms of case fatality rate, and also in terms of distribution per sex and age of this outbreak. We took a sample. We are considering when we did this study, and we are providing the denominator here. You will see that the outbreak is mostly affecting young people from 15 to 44. Mostly, this is the very active tranche of population, because don't forget that we are talking about mining activity. These young people, they are moving from a place to another one, and they are in contact with so many other people. This is why they are so affected. We also see that the case fatality rate among children 0 to 4 is higher than others. We'll have opportunity to discuss that. And this one is guiding our action on what we need to do to ensure that we are providing appropriate care, not only to male and female, but to all tranche of population age that we have. Next slide. What did we do? Because we started to see some countries imposing travel restrictions, we started to see some countries requesting Africa to strengthen the entry and exit at airport and all other places. We decided to release some guidelines. The first one that was released 2 days ago, it's about travel restrictions and public gathering. And we are clearly saying that for now, based on data that we have, the risk is low. And we cannot stop gatherings in areas where we don't report Ebola outbreak. But in area where we have the Ebola outbreak, we are making some recommendations on what must be done because we need to preserve those who are not infected and to protect those who are already contact or infected. We also released a guideline on how we can enhance the surveillance at point of entry. And this one is coming with some forms. And what we are doing, we are harmonizing the QR code in Africa because we want, when someone is flying, the country receiving that person must already know that we have the information, the person was screened, and this is the status. And if they need to screen again when the person lands, they will compare then the result. And that one, we are also doing that because we need to send a strong message to continents and countries where travel restrictions are not applied. And they must know that in Africa, we are doing our best to improve and to protect not only ourselves, but also others. Next slide. We still have some challenges. We have a list of challenges, even more than what I'm presenting today. But I will draw your attention to 3 of them. The first one is the contact tracing. We already discussed that. We saw that we are just around 17 to 30% of people we need to follow up under the contact list. And that one, if we don't improve there, we will not say that we are winning. The second one is about security. I have my colleagues today who are in Beni. There was an attack of rebels. People are killed. They wanted to fly to Butembo. Even the UN decided to stop all flight. This is a major issue. We cannot respond to this outbreak when we are facing insecurity. And this is why we are calling to our leaders to give us access to people. And as the EU requested, we need really to have this ceasefire. Otherwise, this outbreak will continue. And this outbreak doesn't know who is rebel, who is not rebel. The third one is about some gaps that we saw in terms of safe and dignified burial. You'll see that in the next slide. Next slide. You see, out of 49 teams we wanted to have when we conducted this assessment in 15 health zones, just a sample, we have available 7 teams. Out of 88 vehicles, ambulances we needed, we just have 98, I wanted to say. We just have 7. And out of 500 people we need, we just have 84. When we have this huge gap in an area that is a critical one because we know what's happening. We saw some videos. We in a context of mistrust. We need to have sufficient funds to fill that gap. And this is just one challenge I wanted to highlight today, to say that we are still struggling because we don't have appropriate funding to address this issue. Next slide. This is why our Joint Continental Preparedness and Response Plan is the most comprehensive document to date to respond to this Ebola outbreak and also to prepare countries that are at risk. We have 11 pillars, and we already discussed that. All of these pillars, per country, per partner, figures are provided in the plan. And next slide, you will see that for the 11 pillars, we need around $518 million. And this breakdown is known. What we did, we took data from countries, their plan, and we provided here. Next slide. Africa today is not just Ebola, but we still have other outbreaks. I think for those who are with us since January, you know that we said we want to reduce the number of outbreaks every year. What is driving me is if you compare total of moderate and high risk event, in 2025, we had 120 for the same period of time. In 2026, it's 114. Yes, someone can say only 6. But believe me, 2025 was better than the 3 previous years. And if we can continue to build resilient systems at country level, if we can continue to reinforce our capacity in all areas, maybe we can reduce number of public health events. So far, we have cholera in 15 countries, and you'll see I will discuss cholera in DRC. We have measles, we have still mpox, even if it's no longer public health emergency of concern security, and other outbreaks. Next slide. Let us discuss measles. You will see, while we are fighting Ebola, we can't forget measles. You'll see that the trend that we have now in 2026, from week 1 to week 22, is almost the same trend we had in 2024, but more than what we had in 2025. We need to sit with our countries and to really invest to stop measles. We have vaccines. Why the vaccination rate is too low? This is something we need to discuss with countries. Ebola, Bundibugyo, we don't have vaccine. We are every day complaining. Why are we not using vaccine, measles vaccine, when we know that it's available? Next slide. You'll see measles in DRC. I put in red South Kivu and North Kivu, where we see the 2 regions are the main drivers of measles in DRC. And as we know, these 2 regions are also affected by insecurity. This is why you will see the coverage, the measles coverage in these 2 regions is low. If people, they don't want to hear what we are saying, we are repeating that. Ceasefire, ceasefire, ceasefire. We need to access this zone. We need to vaccinate these children. And we need to make these regions safe. Otherwise, other countries are also exposed. Next slide. Yes, I wanted just to show you that we are making progress in terms of mpox. We still have a few countries where we have some cases like Madagascar, Guinea, but overall, we can see week after week how we are decreasing number of cases and even death related to mpox. Next slide. I think that one was my last slide. And before maybe stopping our presentation, let me invite Professor Salim, who is, as I said, in Ituri. He will share with us what he already see in Ituri, and it can help our conversation today. Over to you, Prof.
Thank you very much, Director General Kaseya. It's a pleasure and honor to be here with you. I'm speaking to you from the city of Bunia in Ituri province. Since I have arrived, I've been looking at various aspects of the response and spent quite a bit of this morning at one of the hospitals where the earliest cases were identified and looking at exactly how we are managing the process there. I think we've recognized that this disease is increasing, and right as of our visit today, there were 22 patients in that particular hospital, 5 of which were healthcare workers, 2 doctors and an anesthetist. That's just giving you some idea of the risk frontline health workers are facing. So I wanted to be here to assess the situation firsthand, and as a scientific advisor and as chair of the group that provides scientific advice to the Africa CDC, to know that our advice is able to help because it's grounded in the reality. On that note, thank you very much, DG.
Thank you, Prof. Please stay with us. Maybe you will also help for some questions that journalists will ask because you are there with colleagues. Back to you, Saran.
Thank you very much. So now we're going to move to the Q&A segment. So journalists, you can send your questions in the Q&A box, or you can raise your hand. I can see some of their hands raised live on Zoom. Please indicate your full name and the name of your media organization. So I'll start with Banjot Kaur.
Hi, thanks.
Hello.
Can you hear me?
Yes, we can hear you.
Thank you very much for taking my questions. I have 2 quick questions. The first about contact tracing. What is the ideal percentage or something which you are aiming at that you should achieve? And what are the key obstacles in improving the contact tracing? My second quick question is about conflict. If the DG or anyone else could explain what exactly is the nature of conflict and which is preventing the efforts to control this outbreak. Thank you so much.
Thanks a lot. So we're going to take a second journalist, and then I'll let Dr. Kaseya answer. So Paul Adepoju.
Hi, thank you very much for taking my question. My first question is extending what the last journalist mentioned. The joint WHO and Africa CDC plan to respond recognizes insecurity as a major barrier and proposes coordination, other responder safety measures, but there is no detailed political or security solution to the armed conflict itself. So I'd like to know, and I think during your presentation too, you highlighted the magnitude of the problem, but who is addressing this problem? What is the channel of engagement to ensuring that this is well addressed? Then you've also highlighted how much people that have been tested are not being reached. So why are the samples collected, but the mechanism to track the people is not in place to quickly reach them? If this is ongoing, how much of a crisis could this inability to quickly identify people that test positive could pose to the overall response plan itself?
Wow,
Thank you
Paul,
very
this
much.
is a very, very long-winded question. So thank you. We are going to let Dr. Kaseya answer the questions and probably also maybe share other colleagues would come. But Dr. Kaseya, over to you.
Yes, I will answer the first question, the contact tracing, and then my colleagues who are in the field, they will answer the second question. It means Professor Yap and maybe Wessam will also come in. Yes, the contact tracing is low because the response is facing a double gap. Many contacts have not yet been identified. We discussed that. And some listed contacts are not being actively followed. The drivers are rapid geographic expansion, delayed detection, high mobility, insecurity, community resistance. We saw that. People attacking health workers. Today in Beni, they destroyed isolation center, they destroyed treatment center, and uneven tracing capacity by health zone. You know, we still have a lot to do, a lot. And for us, this contact tracing becomes one of the major indicators to say if we are moving in the right direction. If you compare, I think you saw in my slide, if you compare the contact tracing in Uganda, you'll see that out of 19 cases, we're expecting around 800 contact. Uganda has 792. That represents almost 90-something%. And out of the 792, 91 are under active follow-up. And as you know, WHO is giving us to say that the follow-up is adequately conducted. We need to be between 90 to 95% to follow under active follow-up. Uganda is doing a great job. I can say, based on the figure that we have today, I can say the outbreak is really under control in Uganda. And even we moved from 2 confirmed cases to 19 confirmed cases. Those who are confirmed cases are coming from the contact list. It means also we have no evidence of community transmission in Uganda. Then those who are imposing travel ban to Uganda are just wrong, totally wrong. But let me quickly, before handing over to my colleagues, Paul, about the armed conflict. I want to also share with you, you can talk about it next Tuesday, 16th of June, we have a high-level presidential meeting. All African head of state will meet virtually from 3 to 5 p.m. Eastern African time. The meeting will be led by the president of Burundi, who is the AU chair. And one of the topics to be discussed will be, what can we do in this environment to give access to health workers and to allow population in need to get the support they deserve. We as Africa CDC, we cannot address this issue, but our leaders, they have to tell us what we can do. We are waiting for this meeting, and I'm so excited that finally this meeting will take place, and we hope to have good resolution from our leaders. Yap and Wessam for other questions, please.
Thank you so much, DJ and Paul, for the question. As you mentioned, DJ, there is still a lot to do. We know that everything starts and ends with the community. The good news is that community engagement has started at the highest level with the Member of Parliament in Ituri. That was done by the governors and together with the Minister of Health, the Minister of also Information. And now scaling down. This week, it was the medicines of the zone, the people who are really leading the response at the health zone level. And then we scale down to the community healthcare workers. Those are the key people who will ensure the active surveillance, the community engagement in terms of communication, but also in terms of contact tracing that you've been highlighting, which is quite critical. So what we are pushing now with the partners and the leadership, that's the mission that you all mentioned, our colleagues are currently in Beni, we were in Mongwalu and also in Yankonde, is to ensure that we fast track that decentralization and have those 2,000 community healthcare workers in the ground, engaging the community, making sure that they are part of the solution and that they will come by themselves when they have symptoms. We start seeing that. We were this morning at the one ETC as mentioned, and the message is that they start seeing some people who will come because they've heard in the radio, they've heard that some of the relative has maybe some symptoms, so they come by themselves. But we need to fast track and go and track them in the community. That's what I can add, and maybe let Wessam answer, complement the question.
Thank you, DG, and thank you, Prof. Yab. As it was mentioned, contact tracing, this is one of the very important tools that we currently have to control the situation. As you know, we don't have vaccine, we don't have treatments for the current Bundubugia virus. So we need to return to the basics of the epidemiology and control for those outbreaks. And contact tracing, this is very critical. And to do contact tracing, first we started with identifying the case and do case investigation to identify those contacts. As the DG highlighted, for each case, we are expecting between 20 to 40 contacts. Those contacts are community health workers following on a daily basis to measure their temperature, identify if they have any symptoms related to Ebola. And once any symptom identified or increase in body temperature, we refer them to Ebola treatment units because they become like suspected cases and start doing investigation. Unfortunately for now, because of the evolving security situation in the region, the number of contacts is almost 50% less than the expected number of contacts that we should be following. And out of those initial number of contacts that we are currently following, which is almost 50%, we're able in most of areas to do contact tracing for 50% of those least number of contact traced. So this is a big challenge. We're trying to address it at the work through deployment of community health workers, but also the more important at political level, we need to ensure that there is secure access for our rapid responders that are in the field to get access for those areas. As DG highlighted, situation is evolving, insecure situation in Beni that preventing our team from going there. So those are critical issues to improve our response and make us able to control the situation quickly. Thank you. Over to you.
Back to you, Sahan.
Thank you very much. So we are going to take a couple of other questions from journalists. Kat Lai or Lay.
Thank you. It's Kat Lay from The Guardian. I wonder, could you give us an update, please, on how much financially has been pledged to the response and how much has actually arrived? And given that we're now almost a month on from the outbreak being declared, How optimistic are you feeling? Are we doing better or doing worse than you might have expected at this stage?
Thank you very much. And Rachel Abuja.
Thank you so very much. Thank you, DG, and I can see Dr. Mercy today. It's nice seeing you again, and I hope you're keeping safe. So my question is for Professor Salim. From your field assessment in Turi, you mentioned healthcare workers among those infected. What does this tell us about infection prevention control measures in frontline facilities, and what urgent actions are needed to better protect healthcare workers while still ensuring communities or continuity of care in such high risk setting? Then DG, when you try to mention affected persons for Ebola, you said 15 to 44 years, and I heard that calmness in your voice. So what do you think we should do rapidly to ensure that this particular age group do not have to suffer for all of this? Thank you, and over.
Okay, thank you. I think I may just add one more question, so at least we'll have. So we have a question from Eva Kravchik, and the question is: does Africa CDC have an update on talks with Kenyan government regarding an Ebola quarantine center for U.S. citizen, or is counseling the High Court that is dealing with the matter? All right, so over to you, Dr. Kaseya, and I think there is also a question for Dr. Salim, so.
Yeah, no, thank you so much. I will start with a question from Kate. Yes, we have a plan, $518 million. We know that to stop this outbreak, because we don't have vaccine, because we don't have appropriate and approved therapeutics, we are only relying on public health measures. And we are also in a context of mistrust of communities, in a context of insecurity. It means to reach this area, it's costing a lot than the Ebola that we have in Bulape. Putting everything together, we are saying that out of this 518, we started to receive some pledges, but these pledges were not real. Even we had some double counting. We moved from 498 million, that was the pledge when we launched the initial plan just for countries. Today, we are talking around 212 million. That is almost there, including in-kind support coming from so many other partners. This 200 million almost we are talking about are what we can say we know the source. In addition to that, we know that others are coming, are repurposing some funds. I will give you a concrete response to this question after the meeting we'll have on Tuesday. Because what I'm getting, many African leaders, they want to pledge funds. Many other partners, they want also to confirm or to pledge, and we'll be taking note of all of these pledges, and we'll share with you how much we already secured. But my message is clear to Western countries. We are doing our best, but we want to keep this disease where it is. We need to contain that. The best way to contain that is not travel restriction. the best way to contain that is to provide appropriate funding and support for us to stop the spread of this outbreak. It's linked to the question that Rachel was asking. You know, we are talking about young people, 15 to 44, who are the most affected one. And we know, as I said, they are the most affected one because they're exposed to some social roles, including mobility, working in the mining sector, and trade movement, but also burial practices, because we saw that most of these people were attacked during the funerals are mostly young people attacking them. Then, what can we do? We need to be innovative on the way to address that. We cannot resolve or we cannot provide solutions without themselves. It means the majority of community health workers must come from this range, 15 to 44. This is the first one. Second, each of these groups, they have what we call leaders. We need to bring these leaders to become community health workers everywhere. And we need to give them KPIs, key performance indicators. You want to get what we are giving to community health workers, that is agreed. We need you to show us that in your area, there is no longer violence, there is adherence to messages, and we can also see that young people are contributing to disseminate information. This is what we can do, but there are other solutions that we can also bring, like using the mass media, using the focus groups, you know, so many approaches, but we really need to target them. If we don't target this group, we'll not stop this outbreak. About the Kenya issue, I think we discussed that last time. We are saying that our conversation with the Kenyan government, they are telling us they have a preparedness plan. They want to have 23 centers for isolation or treatment. And one of them can be used also when Americans are affected, rather than flying to Germany, as it was the case, or to other places, they can also fly to Kenya. This is a decision from a sovereign country. They took time to analyze, and they know what they need to do to ensure that they could not be impacted negatively by the decision they are making. I trust the government of Kenya, and they know that any type of support they need from us, they can get it. Prof, maybe for your question from Rachel.
Yes, thank you very much. Just the issue of healthcare workers. For a disease that's a hemorrhagic fever, as is the case with Ebola, frontline healthcare workers are always at higher stress because they are the ones who are dealing with the patient's blood and the patient's secretions, and they are the ones who are directly involved in the care of the patients, and so they carry a risk. What is the big issue is that these are hospitals that are not specifically designed in order to deal with hemorrhagic fevers. They are general healthcare services. And what's happening is that patients are presenting initially with a range of symptoms that could be diagnosed as pretty much any infection and can easily be mistaken for other common conditions like malaria. So it's in those early stages that we need better triage systems. And so the hospital I went to today, I was very impressed, I have to say. I mean, when I saw what Africa CDC, WHO, and ALIMA have done, was outstanding. They created a triage area with a plexiglass between the patients and the screeners. They have a mechanism to collect the samples without any exposure to healthcare workers. And for me, the most important thing, they created green zones and red zones. So it's very clear now where you can walk and work and do whatever you need to as a healthcare worker without any risk or very low risk. And you're dealing with red zones, which are high risk zones where you have to ensure you have the appropriate PPE. And the red zones are only accessible at this hospital I went to see, they're only accessible after doffing on PPE. So the problem was that didn't exist when these doctors were exposed. But those changes that are being made now will protect the next group of healthcare workers. And I think it's that important step that's been put in place that I have to say is quite reassuring from my perspective. Thank you.
Thank you very, very much. So the next journalist is Carrie Cullinan.
Thank you so much. My question relates to the nature of the US engagement with the Ebola response. How much money has been received from the US? And also, is the US CDC or its experts engaging in any way with the CDC WHO incident management team? Because as we know, the US is no longer part of the WHO and is currently not engaging with the WHO in other forums. Thank you.
Thank you. The next question is, oh, I saw a hand and it's not there anymore. So there is a question here from the Wall Street Journal reporter, and is, can you shed more light on how China's medical teams are helping out in the current response efforts in Congo and Uganda? How much funding has China extended to the Africa CDC to assist in the ongoing response efforts? If I can, I'm just gonna squeeze in another question so that we'll have that. So there's a question from Andrea Ortiz. Given the persistence of the Ebola virus in wildlife reservoirs, what are the current priorities or main challenges in integrating wildlife surveillance with human health early warning systems?
Yes, thank you so much. I will start with the first question from Kerry. I will also support for the second one. I will ask Tolbert and Wesam to respond to the third one. The US engagement, you know, overall the US remains the first partner for the global health security. And we know that announcements were made by the US government, and we also know that they are supporting some organizations like OCHA. And currently, we want to understand how much money from what the US gave to a number of partners can really go to support the response, and as it must be known by the government. I think this is the conversation that we are having, and because we know that the US, they will attend the meeting on Tuesday, they will have opportunity to give us a reliable amount of money that they are putting to the response. Regarding China, you know, in Africa, we are working with all of our partners. And China is an important partner for African countries, working almost in all African countries. And we know, based on the information that was communicated by us, to us by ministers, that our countries are getting support from China. This support can be financial support, human resources, commodities, but they are getting support. About Africa CDC, for what we know, China made an announcement to provide $2 million to support the response. And also, we know that they are thinking about additional support. We will continue, and we know on Tuesday, China will also attend. They will give us an overall picture of the support they are providing for Ebola outbreak. Tolbert and Wissam for the third question, please.
Thank you, DG, very much. Thank you for the fantastic question from the journalists about the persistence of Ebola virus disease in wildlife. We know that this in wildlife, and there's united split over of Ebola to human. At this time, our concentration, we know the species that caused this outbreak, the Bujumbujo Ebola virus disease outbreak. Our main concentration, as DG said rightly and other speakers, is to stop the human-to-human transmission. That's our first concentration. That's where you need to do all of the public health countermeasures that we have in our toolbox, that's surveillance, contact tracing, and colleagues talk about case management, isolation, and all of that. We also know that we need to continue the surveillance system because once there is human-animal environment interface, we will always have these outbreaks because of our environment and the human encroachment on wildlife. That's why we are getting this outbreak. But it is important, as you mentioned, to use the One Health approach, that is making sure animal surveillance and human surveillance. But our major concentration and where should we invest the resources right now? It will be investing the resources in the work we are doing with surveillance, we're building the treatment units, we're isolating people, and then later on, we can concentrate on doing animal surveillance and testing the bats, the monkeys, which are some of the etiology or source of the outbreak that we are caused, that is happening right now. So it's important to check the animals and do animal surveillance, but our concentration, step one right now, goal is to stop the outbreak. And to stop the outbreak, since we don't have vaccines and therapeutics, is to do what we are doing right now, ramp up all of the interventions that we mentioned earlier. Thank you. Over to you, Wessa. Thank you, DG.
Thank you, DG. And I think this is a very important question, especially when we start talking as Africa CDC about the importance of One Health approach. Health of human being is highly connected with animal health and environmental health. And when we speak about this Ebola outbreak, we speak about zoonotic disease, and it's coming from animal to the human being. So this is why it's critical. If you start looking at the continental strategy for Bundibugyo outbreak response, one of the critical pillars in this strategy is One Health, because we believe to best control the situation, we need to working closely with our animal health team. This is why we establish this important pillar. So while we're focusing on controlling the spread of the disease, our team within One Health in Africa CDC, WHO, and other animal health organizations, they are working hand in hand to doing investigation for the source of this outbreak. Samples, they start focusing on collecting samples from animals to detect what are the potential sources that led to spread this outbreak at the beginning. So in brief, One Health is a critical component. It's already included in the strategy for controlling this disease, and the team currently working on investigation the possible source for this outbreak. Over.
Thank you both. We'll take a couple of other questions. There is, I think, unfortunately, the hand is down now, but there was Esther. Let me see. Esther, are you still? Yes, Esther Nakazi.
Yes, I'm here. Thank you
Okay,
very
please, over to you.
Thank you very much, Saran, and thank you, DG, and the rest. So my question is about experimental drugs that can be used in this outbreak. I know that there are trials that are about to start, but I just want to understand whether this has already happened, whether permission has been given by the countries to try to deploy these experimental drugs with the patients, and what is the likelihood that the epidemic will stop before we actually start the trial. Thank you, and over.
Thank you very much. There is a question here from Reuters. Could you explain where Africa CDC is getting its cases and death numbers? We see that they don't really match numbers that are provided by Congo's government every evening. I will add another question here from Nature Africa. 500 million is quite a bit of money. How much are you envisioning could be raised from AU members? And can you explain how this funding could be used to mitigate or at least prepare African countries against future outbreaks?
Yes. The first question from Esther. So far, no African countries is using experimental drugs against Bundibugyo. But as we said, we have candidate vaccine, we have candidate therapeutics, we need to start what we call the clinical trial, and countries agree with clinical trial. We are working with the African Medicine Agency for all regulatory aspects, and we believe that it will help when we will make decision to move on. Then, regarding the question, the writer question, I will ask my colleagues Yap and Wessam to respond to that. But let me tell you, we have reliable data, but they will give you more information. How much can we expect to raise from African countries? And how can we use this fund to mitigate or at least prepare African countries against future outbreaks? I think this is a fundamental question. Why Africa CDC decided to organize a meeting with head of state? Because it's Africa CDC organizing that. We are organizing this meeting because we want our leaders to play solidarity, to contribute. We have some target. If today we have something between 50 to 100 million coming from African countries, I will say, good. My target is almost around 100 million, 18 to 100 million. I will call that a success. Then, What now we can get from partners will be on top of this $100 million. Am I optimistic that we can get 80 to $100 million? I like to be optimistic every day. I like to be positive. I'm waiting for Tuesday. And I hope you will ask me this question after the Tuesday meeting. What can we do, not only to respond to this outbreak, but to prepare African countries against future outbreaks? This is what we are seeing every day. Look, this outbreak we had in the eastern part of DRC, $1.2 billion were invested. Go there, almost nothing. If we compare with Mpox, around $500 million, but the legacy of Mpox is huge. We managed to decentralize the lab network. We managed to bring from 7 to 48 countries with capacity for genomic sequencing. Yes, we got also support from Mastercard Foundation at that moment. But with Mpox, we saw the progress we made. With Mpox, a country like Burundi, they have only one lab. Now they have 42 labs. DRC and so many other countries, they benefited. We can today say the difference between this Ebola in DRC and Mpox, it's because when there was this Ebola, there was no Africa CDC. From Mpox, Africa CDC is leading the agenda. This current outbreak, we are responding to that by building also capacity of African countries, by making sure that we are manufacturing appropriate tools, vaccines, and therapeutics. This is what is making things different. And we'll talk about the legacy of this response, and you'll see what we are doing. Yap and Wessam to respond to this question from our colleague from Reuters.
Yes, thank you, DJ. As you usually say, data are part of the country's sovereignty. So I will allow Dr. Mercy, who is leading the data analytic and AI pillar of our IMST and the plan, to really tell us how the data are generated, how we contribute, and how they are disseminated. Over to you, Dr. Mercy.
Thank you so much, Professor Yab, and thank you so much, DJ. That question is quite very, very important. I must attest to it. To start with, Africa CDC has supported the DRC to establish the data tool that supports routine data collection from the field. And that is the DHIS2 tracker, which of course we are expanding towards also helping us to the country to detect and track even contacts at point of entry, which is work in progress. Again, during this response, the country has set up a team to validate data that comes from the field. And this is done every 5 p.m. So when the data comes, Africa CDC sits with other experts from Ministry of Health and WHO to look at the data, and we validate the data together. At this time, we have the numbers, but we cannot release the numbers because this has to be led by the country. So we let the country release the numbers first, and then we follow next. So the numbers that has been presented to you by the DJ, of course, today is the 11th. These numbers were published by the country on the 10th. And in the next few hours, you're going to get new numbers that are going to be released on the 11th, but these are numbers from the 10th. So this is just to tell you that we have the numbers, which of course guide our strategic actions, guide our interventions and our target areas where resources should flow into. But these numbers would only be made available to you by Africa CDC after it has been released by the Ministry of Health. But we do have them, and we are tracking them accordingly. Over.
Yeah, thank you. Thank you so much. Professor Karim, I understood that you wanted also to provide some information regarding therapeutics.
I'm happy to do so very quickly, just to say that there are two licensed antibodies, monoclonal antibodies, that are used to treat Ebola. The challenge is that both of those antibodies, one is a single antibody and the other is a combination, do not work against Bundibugyo virus. And so we need to be developing new antibodies, and that's already underway. The second is that a drug called remdesivir that was used during the COVID-19 pandemic, it has animal data that suggests that it may be effective against Bundibugyo virus, but the data are very preliminary. So the priority is to do clinical trials of these drugs, and they're being coordinated by the WHO, and there are several sites within the DRC that are involved in it. I have to say I'm very optimistic because I think remdesivir has a good chance of showing efficacy. It's quite quick to show efficacy because we have the patients that are there in the hospitals right now. And if remdesivir does work, it's quite a cheap drug, readily available. Generics are widely available, and it's an injectable. It's quite easy to administer. So I'm pretty optimistic that remdesivir may work, but we don't have the data yet, and we'll have to see. And finally, the question about, will this epidemic end before we can do these trials? Well, I'd love to have that problem, that the epidemic ends quickly. But I anticipate that by the time we go into the field with these clinical trials, we will still be having a significant number of cases. Thank you.
Just to follow up.
Please, because, yeah, sorry. I need to take two more questions, so I will just allow other journalists to ask questions. Apologies. So there is one question that came from Ruud Elmendorp for the Dutch Telegraph. How many in percentages are the infected health workers compared to the primarily infected people? And then the second question is, there's a hand and it's Kemo Cham. Is Kemo Cham still here? Not here. Okay, so we had another question was for Professor Karim. How feasible is it to have these triage protocols and measures, including PPE, in place in times of non-outbreaks? Or do you imagine only putting these measures in place once an outbreak has been reported? And this is going to be the last question because we are well over time and we need to wrap this up. So over to you, Professor Karim, and then DG, if you want to answer the first question.
Sure, I'll be very quick. In place right now are not really sustainable in the long term. And in fact, would be counterproductive because you don't actually interact with patients directly. It's always done through a screen. And that's not the best way to build rapport with patients. So it's something that is instituted when there is a high risk or when there's an outbreak that's been reported. But once they're instituted, they're pretty good and they work quite well. So I think that they're readily doable. They need to be implemented when they are required and generally cannot be done or would be counterproductive in routine care. Thank you.
Thank you very much. Over to you, Dr. Kaseya.
Yes, my answer is simple. So far we had 29 health workers infected in DRC. 5 of them passed on. 5 health workers infected in Uganda. All of them are alive. This gives a total of 36 health workers out of 635. It's almost around 6% of health focus compared to the total of people who are infected. And I want also to take this opportunity to correct something I said. Maybe I said I have a colleague, Dr. Justice, who is the incident manager for Ituri. He's now in Beni. He wanted to fly to Butembo, and we have this incident, and the treatment center that is destroyed is not in Beni, but it's in Butembo. I wanted to correct that. It's in Butembo that the treatment center was destroyed. With that, back to you, Saran, if you want me to conclude, maybe.
Yes, please.
Thank you so much. Let me thank all journalists who attended this press conference. Let me thank my colleagues who are in the field, who are exposed, and we are praying for them to continue to be safe. Let me pray also for WHO, UNICEF, and all other colleagues who are supporting the response. I want also to say thank you to the two governments, DRC and Uganda, for the continuous effort to work together for the cross-border activities. I want also to thank our partners for the support they are providing, and we'll continue to have this conversation. And I think when we'll meet after the meeting on Tuesday, that will be the next press conference on Thursday, I will be in a better position to update you on the figures and on some political decisions that will be made. Thank you so much, and it will be my great pleasure to see you again next Thursday.